Great. Well, I'm very excited to be here. Thank you for inviting me to speak. Give me a moment while I get my slides up.
You bet. We'll make sure you're up and running.
Okay, great.
Perfect. Thank you again.
All right, fantastic. So my talk is on a practical plant-based approach to optimal heart health. And I consider myself to be an interventional and preventive cardiologist. I have the training to open up blocked arteries, but I also like to use my knowledge and skill to help people to prevent needing those things in the first place. This is why I love what I do, because I can use my knowledge to prevent things, and I can use my knowledge if something bad happens to help save a life. And I love being able to do both of those things, preferably to prevent a heart attack, but I can also help save somebody, which is neat. You heard about my book, The Vegan Heart Doctor's Guide to Reversing Heart Disease, Losing Weight, and Reclaiming Your Life. The reason I wrote this book is I really wanted to convey to not just my patients, but anybody about what I would want them to know about heart disease, to know what heart disease is, what the risk factors for heart disease is, and particularly how to take control of your life to keep your heart healthy for years to come. Heart disease is important. It is the #1 cause of death for men and women in the United States. And importantly, 80% of heart disease is preventable. This is a graph from the year 2019 and 2020. And even with the COVID-19 pandemic, heart disease was still the #1 cause of death. And I circle stroke as well, because stroke is really along the same lines as heart disease. The same risk factors of heart disease are also risk factors for stroke. There are several different types of heart disease, and today what I'm really going to focus on is coronary artery disease, which is plaque in the arteries of the heart. But briefly, there are other forms of heart disease that I treat in my daily living as a cardiologist. There is congestive heart failure, which is a condition in which the heart, for some reason, cannot handle the volume of fluid in the body. There is hypertension, which is high blood pressure. And I'm going to talk a little bit about that as well later on in my talk. Arrhythmias, which are abnormal heart rhythms. Valve disease, which is abnormalities in the valves, which are the structures between the different chambers of the heart. And then congenital abnormalities, or abnormalities of the heart that people are born with. So what is coronary artery disease? Now, coronary artery disease is plaque within the arteries of the heart. Now, arteries supply blood and oxygen and nutrients to the tissues and muscles of the body. The heart itself is a muscle and requires oxygen and nutrients in order to function. Now, the small little squiggly red things that you see pointed to on the heart, those are called coronary arteries. Those are the arteries that supply the heart muscle. And if you were to cut one of those open to look inside to see what somebody with coronary artery disease has, you would see that there is plaque. And plaque can develop not just in the arteries of the heart, but also can develop in other arteries of the body. We treat all coronary artery disease with medications and lifestyle, but sometimes more invasive approaches are needed, such as in the situation of a heart attack or an unstable heart situation. Now, a coronary angioplasty, that is a procedure that I am trained to do and can literally save the life of somebody in the midst of a heart attack. As an interventional cardiologist, I can go through either the artery in the leg or I can go through the artery in the wrist. And I can feed my catheters up to the heart and inject dye into the arteries of the heart and take X-ray pictures to look for whether there are significant blockages within those arteries. I can then take a wire and feed it into that coronary artery, feed a balloon over that wire, inflate that balloon to push that plaque aside, and then put a tube in called a stent to hold the artery open. This is a procedure room where a cardiac catheterization is done. You see there are two people at the table. One of them is a physician, the other would be a technician. And there are monitors in front of them. They can see the blood pressures of the patient. They can see the images of the heart. And the patient is lying on the table with what we call an image intensifier above them and an X-ray tube below them. And we inject dye and take pictures, and that's how we see the arteries. So bypass surgery. Now, bypass surgery does not clean anything out. It simply bypasses. So we create a conduit for blood to go around a blockage. We either use arteries or we use veins. The main artery that we would use to bypass is called the left internal mammary artery. It's an artery that runs along the front wall of our chest, and it's really an extra artery that we don't need, and a surgeon can reroute that onto the heart to bypass a blockage. Now, we can also use arteries from the body elsewhere. We can use the radial artery, which is in the wrist. We can also use the internal mammary artery on the other side of the chest as well. But often surgeons will need other vessels, and often they will use veins. And particularly what they will do is take the saphenous vein, which is a vein in the legs. It's an extra vein that we don't need, and they can sew that to the aorta, the big blood vessel coming out of the heart, and then route that around the blockage onto the coronary artery. Now, downsides of coronary artery bypass surgery, the obvious: who wants to have their chest cut open and undergo a surgery that requires a prolonged recovery? But also, bypasses aren't necessarily very sturdy. The bypasses that are arteries tend to be for the duration of one's life, but the vein bypasses, about half of them after 10 years aren't open anymore. Now, there are multiple risk factors for coronary artery disease. There are a few that we simply can't change, but there are a few and several that we actually can change. So the things we can't change is we can't change our genetics. There are certain genes that predispose people to being more likely to have coronary artery disease or heart attacks. And gender. Men tend to be more likely to have heart attacks and coronary artery disease than women, though after menopause, women do tend to catch up. Now, there are multiple modifiable risk factors. Smoking being a big one that has improved over years as there are fewer people who do smoke. If you're a smoker, you should quit. That goes without saying. Diet is definitely something that's modifiable, and by improving diet, there can be great improvement in reducing the risk of heart attack, and even if you've already had heart problems, of helping to stabilize and reverse the plaque that is in the arteries. Exercise is potent in reducing risk of heart disease, controlling blood pressure, controlling cholesterol, controlling diabetes if you have diabetes, and managing stress are all very important in reducing risk of coronary artery disease. Now, the problem is, unfortunately, here in the United States, our diet isn't very good. And that is why I unfortunately have a fair amount of job security. The standard American diet only consists of 9% vegetables, fruits, and legumes. About 30% of the average diet is animal products, and 39% is added fats, oils, and sugars. So this, unfortunately, is a diet that lends itself towards disease. Now, studies worldwide have shown that diets that are more plant-based have a lower risk of heart disease, high blood pressure, type 2 diabetes, intestinal disorders, several kinds of cancer, osteoporosis, kidney stones, and gallstones. Now, I'm going to quote one of my heroes, Dr. T. Colin Campbell, who I'm going to be on a panel with tomorrow night. He says the vast majority of all cancers, cardiovascular disease, and other forms of degenerative illness can be prevented simply by adopting a plant-based diet. And in short, he obtains this information by studying China and studying the parts of China where people were following a more traditional diet compared to those who are consuming a more Western diet. So what is in a plant-based diet? And I want to be clear that there is a distinction between plant-based and vegan. Vegan means no animal products, whereas plant-based is more of a healthy vegan diet. So when we talk about a plant-based diet, we're talking about a diet that has plenty of vegetables, grains, beans, fruits, nuts, and seeds. It's a diet that does not have animal products. It may include some of what I would call smartly processed foods, things like tofu, like plant milks, tempeh, even dried fruits. And heavily processed foods are at a minimum. Now, this is not a healthy plant-based diet. This is a vegan diet. Yes, potato chips and soda do not come from animals, but they are not what I would consider to be a healthy plant-based diet. However, this is my 2.5-year-old daughter. This is actually from this weekend. She was helping me make dinner. So she's standing in her learning tower so that she can reach the counter and help me out. And she's holding a strawberry while she's helping me cook. And she actually took that broccoli that you see and she broke it up into little florets so that we could put it in our stir fry. So plant-based diets are appropriate for all stages of life. And this is coming from the Academy of Nutrition and Dietetics. They put this paper out in 2016, and they state very clearly that appropriate planned vegetarian, including vegan diets are healthful, nutritionally adequate, and may provide health benefits for the prevention and treatment of certain diseases. These diets are appropriate for all stages of the life cycle, including pregnancy, lactation, infancy, childhood, adolescence, older adulthood, and for athletes. And they further go on to say that vegetarians and vegans are at reduced risk of certain health conditions, including ischemic heart disease, type 2 diabetes, hypertension, certain types of cancer, and obesity. Now, blue zones are parts of the world where people tend to live the longest, and they have a number of things in common amongst them. One of the blue zones happens to be Loma Linda, California, close to where I am. I'm in the Los Angeles area. So what do blue zones have in common? They have close family ties. They tend not to smoke. They are socially engaged. They tend to be moderately active much of the time. And in particular, they tend to eat diets that are more plant-based and tend to consume more legumes. Now, another one of my heroes and another person I'm going to be on a panel with tomorrow night, Dr. Kim Williams. He is a cardiologist at Rush University. He is former president of the American College of Cardiology. And he's got this very memeable quote that I love. There are two kinds of cardiologists, vegans and those who haven't read the data. And we're going to talk a little bit about the data now. The Ornish Lifestyle Program. So Dean Ornish published some of the first research on an intervention of plant-based eating and heart health. But to be clear, his intervention wasn't just diet. He did have his patients consume a low-fat vegetarian diet, but he also incorporated moderate exercise, stress management, quitting smoking, and group support. The diet that he endorsed is much of what we've discussed. So it is a diet that has plenty of fruits, vegetables, grains, legumes, and soy. There was no restriction in calories. Fewer than 10% of calories naturally came from fat. There were no animal products allowed with the exception of egg whites and 1 cup per day of non-fat milk or yogurt. And participants were not allowed any caffeine and only limited amounts of alcohol. So Dr. Ornish's lifestyle heart trial results after 1 year. In his experimental group, he actually found that there was reversal of the average coronary narrowing from 40 to 37.8%. His control group actually had progression of coronary narrowings. Now, the reversal amount looks pretty small, and it is, but I think it's important because what we are taught and what we typically see is that with time, that coronary disease progresses. So to find something that can halt or reverse plaque buildup is a big deal. In his experimental group, there was a decrease in the frequency of angina or heart-related chest pain by 91%, whereas those in the control group actually had an increase in their angina or heart-related chest pain by 165%. And of those in the experimental group, more than 4/5 or 82% actually had regression of their coronary narrowings. Next, I'm going to talk about Dr. Caldwell Esselstyn's work, and I think he's also on the panel I'm going to be speaking with tomorrow night, another one of my heroes in heart disease. And his particular study was called arrest and reversal therapy. His study took place really in the 1990s as well. He recruited several patients who had very severe triple vessel coronary artery disease. These were pretty sick people from what he describes. He put them on a strict vegetarian diet. It was a small study, but the findings were interesting. 21 patients were recruited. 17 patients followed the diet, and there was complete data, including angiograms, to look at the arteries of the heart of 11 patients who participated in the trial. In his study, he allowed whole grains, legumes, lentils, vegetables, and fruit. But what he did not allow were nuts, oils, seeds, avocados, or any animal products. So this was a more than just plant-based. This was a pretty strict plant-based diet. And to highlight just how sick these patients were before they enrolled, of the 11 patients for whom we have complete data on, there were a total of 37 events in the 8 years prior to starting the study. So there were multiple events of increased angina or heart-related chest pain. There was progression of disease, 6 bypass surgeries, 4 heart attacks, 3 strokes, 2 angioplasties, and a stress test that got worse. But after starting the study, there were 0 further events in the 11 patients who were able to follow the diet, which is pretty remarkable. Now, these are coronary angiograms. And like I talked about before, injecting dye into an artery of the heart and taking X-ray pictures. The picture on the left side, picture A, this is the left anterior descending coronary artery that runs along the front wall of the heart. That is before. On the right side is after. And the intervention here was 32 months of a plant-based diet, and this patient did not take cholesterol medications. And we're going to talk a little bit more about statins or cholesterol medications later in my talk. But to be clear, in the 1990s, statin medication was not part of the standard of care of coronary artery disease as it is today. We know that statins can actually help reverse plaque in the arteries. And again, we'll talk more about that a little bit later. This is another angiogram from one of Dr. Esselstyn's patients. It is demonstrating the proximal left anterior descending, the front artery that runs along the front wall of the heart. It is both before and after, and it's 60 months of a plant-based diet. And this patient happened to take cholesterol medication, but nonetheless, a pretty impressive result that you can see with your own eyes. And this is an interesting quote from Dr. Caldwell Esselstyn, because one of the obvious criticisms of his work is, well, that's a really strict diet. That's extreme. Are people really going to eat that way? And his response is, some people think that the plant-based whole foods diet is extreme. 500,000 a year will have their chests opened up and a vein taken from their leg and sewn onto their coronary artery. Some people would call that extreme. Now, this is an image from one of Dr. Esselstyn's patients. It is what we call a PET scan. It's a nuclear imaging study to look at perfusion or blood flow to portions of the heart. And this is another before and after. And this is actually only 3 weeks on a plant-based diet. So this patient before the plant-based diet, you can see that there's an area where the arrow is that's very dark because there's very little blood flow getting to that portion of the heart. And yet after following Dr. Esselstyn's diet for 3 weeks, there is perfusion to that portion of the heart. Now, I think a good question from all of this is, well, let's say I'm not ready to become a whole food plant-based advocate. What if I can improve my diet, but I'm not going to go all the way? Well, the Lionheart study, this was done in France, and it looked at patients who have a history of a heart attack. And what it did was it compared a traditional Western diet that we unfortunately see causes disease and compared that to a more Mediterranean style diet. So those who were put on the Mediterranean diet, they were asked to consume more vegetables and fruit. They were asked to consume less beef, pork, lamb, and more poultry and fish, and to replace butter and cream with a margarine high in alpha-linoleic acid, which is an omega-3 fatty acid. So again, this is not a plant-based diet, but it is a diet better than what is considered to be a Western diet. So this Mediterranean style diet intervention actually led to a 50 to 70% lower risk of recurrent heart disease. So really any improvements in diet, even if you can't go full plant-based, that would be certainly better. Even if you can't go fully that way, there is benefit. And this is a graph demonstrating this. So this is following the patients who were in the Lion Diet Heart Study for 5 years. You can see that the green line shows the number who succumbed to events over time, that there was far more cardiovascular events in those who followed the Western diet compared to those who followed a more Mediterranean diet. Now, this graphic is from the American College of Cardiology, which is the organization that helps govern our profession, cardiology. And they talk about what is a heart healthy plate. And fortunately, in their current iteration of this, they actually do talk about benefits of plant-based, vegetarian, or vegan diets. Now, briefly, I'm going to talk about President Bill Clinton. As we know, he didn't have the best of diets. He was famous for liking to eat a lot of McDonald's and things of that sort. He underwent bypass surgery in 2004. And then in 2010, he actually required an angioplasty. He required a procedure to open up one of those vein bypass grafts in his heart. But he then adopted a plant-based diet and lost weight. Now, I don't think that he was strictly plant-based, but he very much went in that direction. And since then has not had any further cardiac events. So next, I'm going to talk a little bit about blood pressure. So what is hypertension? Hypertension is high blood pressure. It is currently defined as a blood pressure over 130 over 80. Now, at one point, the definition was 140 over 90, but the reason that the numbers changed is because there's been data demonstrating that if you do have a blood pressure that's naturally above 130 over 80, that you do have an increased risk of cardiovascular events. And at this point, nearly half of all Americans are considered to have high blood pressure or hypertension. Hypertension is called the silent killer because you may not have any symptoms at all. You may feel perfectly fine, and yet your blood pressure is high and it is causing damage within your body. Now, what is blood pressure? Now, blood pressure is a measurement of the pressures within the arteries of your body. The systolic is the top number, and that's the maximum pressure within the artery. So that's the pressure within the artery when the heart squeezes and expels blood into the arteries. The diastolic blood pressure is the bottom number, and that is the lowest pressure that the arteries experience, that the arteries will experience when the heart is relaxing and is not pushing blood through. Now, there are definitely consequences of uncontrolled hypertension. One of them happens to be heart attack, that we talked about before. Other consequences are stroke, vision loss, heart failure, kidney disease or kidney failure, and also sexual dysfunction like difficulty in obtaining an erection. And I'm going to show you a couple of graphics that were put together by the American Heart Association to make people aware of high blood pressure. This is a woman who had high blood pressure, who as a consequence, unfortunately, suffered a stroke. And you can see that there is a droop of one side of her face. Looks like the right side of her face has less tone to it. And she has her shoulder exposed. And to me, it looks like that's the site of a pacemaker having been put in, though it could be something else. But nonetheless, there are consequences to elevated blood pressure. This is another one of their graphics. This is a gentleman who shows off his coronary bypass scar because he had a heart attack as a consequence of not having controlled blood pressure. The risk factors for hypertension or elevated blood pressure, similar to the risk factors we were talking about before for coronary disease: smoking, poor diet choices, diabetes, family history, high cholesterol, increased age. As we get older, the incidence of high blood pressure increases, and that likely relates to arteries becoming stiffer. Weight: people who are heavier tend to have higher blood pressures. A sedentary lifestyle is a risk factor. Consuming excess salt in the diet, consuming excess alcohol, and stress. These are all things that are risk factors for high blood pressure. So how is a blood pressure taken? We use a cuff to measure blood pressure, and I'm sure you've all had your blood pressure checked. So the blood pressure cuff is inflated, and it is inflated to a pressure above what is thought to be your blood pressure. So basically, it occludes the artery because the pressure is higher than what is in the artery. Then the cuff is gradually deflated, and there's a stethoscope that you should have listening as the cuff is deflated. When the first sound is heard, that is the systolic blood pressure, because that means that the pressure of the cuff is equal to the pressure of the artery. And then the blood pressure cuff is slowly continued to be deflated, and you're because you're hearing that there is turbulent flow because the cuff is compressing the artery. And then when the noise stops, that is the diastolic blood pressure. Now, blood pressure is one of those things that it's important in how you take it. And as a cardiologist, I'm very vigilant about that, because if the blood pressure is obtained improperly, it really doesn't mean anything. So tips for getting an appropriate blood pressure, especially if you're somebody who checks your blood pressure at home. The cuff should ideally be on a bare arm. The arm should be supported. It shouldn't be raised in the air. It should be supported on a table, perhaps on a pillow at the heart level. Should not be talking while the blood pressure is being taken. You should definitely not have a full bladder, so you want to empty your bladder first. You want to be sitting in a chair that supports your back, so that you're not slouching, you're leaning forward, you're sitting at a 90-degree angle, supported. The legs should not be crossed, and the feet should be flat on the floor and not crossed. Other tips for measuring blood pressure at home is that An arm cuff should be used as opposed to a wrist cuff. Wrist cuffs tend not to be as accurate. Now, how often to check blood pressure? Could be once a day, could be twice a day. For people who are very stable, it could be once a week or once every couple of weeks, but definitely not checking multiple times per day. Don't check blood pressure when you first wake up. Don't check blood pressure when you're anxious or when you're upset. Avoid food, caffeine, alcohol, tobacco for 30 minutes before checking the blood pressure. Sit quietly and wait for a couple of minutes. Other points to know is that you may want to check the accuracy of your cuff. And I tell all my patients, if you want to bring your home blood pressure cuff in, we would be glad to check it against ours to make sure that your cuff is accurate. Of note, the home blood pressure will typically be about 5 points lower than the doctor's office blood pressure. Sometimes there may even be a bigger difference. So the categories of blood pressure. A normal blood pressure is a blood pressure that is naturally with a systolic or top number that is less than 120 and a diastolic blood pressure that is less than 80. It does not mean that we treat with medications to those levels, but if you naturally have blood pressures that are below those numbers, good for you. You have a normal blood pressure and your risk of heart attack and stroke is lower than were if your blood pressures were higher. Now, white coat hypertension, that is a condition in which people will have a significantly higher blood pressure in the doctor's office compared to when they check their blood pressure at home. So that would be an office blood pressure reading that would be over an average of 130/80, but out of office readings that are done properly are significantly lower. And about 1/3 of all people have white coat hypertension. And when I say white coat hypertension, to be clear, I also include my patients who do have treated hypertension, who are controlled when their blood pressure is checked at home, but when they come to my office, their blood pressures are always significantly higher. But a piece of advice before you accept the diagnosis of hypertension: check your blood pressure outside the doctor's office on several occasions. I have an acquaintance of mine who was diagnosed with high blood pressure based on elevated office readings. And he was put on blood pressure medication. He started taking it. He felt awful. He checked his blood pressure at home and it was really quite low. He then stopped the blood pressure medication. He did some home blood pressure readings that were quite normal. He then took his blood pressure cuff into his doctor's office and used his blood pressure cuff along with the doctor's blood pressure cuff to document that, in fact, his blood pressure is significantly higher in the doctor's office and that he has white coat hypertension, but he does not truly have hypertension and should not be on medicines. Now, when it comes to hypertension or high blood pressure, lifestyle is always the first line of treatment. So we start with advising people to consume a diet that is lower in salt. And the guidelines that are given is 2,300 milligrams daily. Now, I, as a physician, don't know that I would be able to accurately count the exact amount of salt in my diet, but the general guidelines that I would give to people would be to consume your meals at home, minimize restaurant food because restaurant food does tend to be higher in salt because that's what makes the food hyper palatable and makes you addicted and want to keep buying it. And also to watch out for packaged foods and soups and heavy sauces that tend to have a lot of salt in them. Exercise is important. Aerobic exercise in particular is potent in lowering the blood pressure. Weight control. So losing weight, if you are overweight, will actually lower your blood pressure. A plant-based diet also lowers blood pressure, consuming more fruits, vegetables, whole grains, nuts, and legumes, and consuming less sweets, sugary beverages, less red meat, and less saturated or trans fats, so less processed foods. Quitting smoking will be potent in lowering the blood pressure and minimizing any alcohol consumption. Now, blood pressure is definitely something that is impacted by diet. So this demonstrates the risk of having high blood pressure based on your diet. So meat eaters are most likely to have a diagnosis of hypertension, semi-vegetarians less, vegetarians less, and vegans in this study, the Adventist Health Study 2, vegans tended to have the lowest risk of having high blood pressure. Now, there are non-medication ways for preventing and treating high blood pressure, and this is a table that describes some of those things. So weight loss can lower blood pressure. So for every kilogram of body weight lost, so about 2.2 pounds, there is typically a 1 millimeter of mercury drop in the systolic blood pressure. A healthy diet, particularly the DASH dietary pattern, which we'll talk about in a moment, also significantly lowers blood pressure. Reducing dietary sodium, consuming more potassium. So foods that tend to be more potassium, fruits and vegetables tend to have more potassium, and eating these foods helps to also lower the blood pressure. Physical activity, we talked about aerobic activity, but even resistance training or weight lifting can help to lower the blood pressure. And then decreasing alcohol consumption. Now, this slide is a little bit dated because it says men less than 2 drinks daily and women less than 1 drink daily. And really the advice at this point is less than 1 drink daily for both men and women. Now, back in the day, before there were blood pressure medicines, there was Dr. Walter Kempner's rice diet. So Dr. Walter Kempner did some research. This is back in the early 1940s when there were no medications available to treat high blood pressure. He put his patients on a diet that consisted of white rice, juice, fruit, and sugar. And patients on this diet saw a very drastic improvement in their blood pressure and a drastic drop in their weight. Other benefits is that their cholesterols were lower. Those who had enlarged hearts as a consequence of high blood pressure had a decrease in their heart size. And there was also reduction in retinopathy or damage to the eyes, which can be a consequence of high blood pressure. Now, what's in this rice diet? So it's almost entirely rice and fruit. It's very low in protein, less than 20 grams of protein per day, contains about 2 to 3% fat, and is exceedingly low in sodium, 150 milligrams of sodium. And on this diet, people were encouraged to exercise. So this is one patient who was put on this diet. So you can see towards the left of the graph in 1945, you can see that his blood pressure was very high. It was hovering around 200 over 120, which is pretty dangerous. He was put on the strict rice diet, and after a few months, his blood pressure came down. He had the luxury of having a quarter of a tomato added daily to his diet. And then as his blood pressure continued to drop, he was permitted an ounce of meat 4 times a week. And ultimately, over the course of 9 months, his blood pressure was controlled with Dr. Walter Kempner's rice diet. It's a little bit draconian, but it certainly did the trick. These are a couple of Dr. Kempner's patients. You can see what they looked like before and what they looked like after. And the diet clearly led to a very significant loss in weight. Now, the DASH diet eating plan, this was designed as dietary approaches to stop hypertension. And this is the standard recommendation that patients are provided. So patients are asked on a 2,000 calorie diet to consume about 6 to 8 servings of grains, 4 to 5 servings of vegetables, 4 to 5 servings of fruits, 2 or 3 servings of low fat or fat-free dairy products, 6 or fewer servings of meats, poultry, and fish, some nuts, seeds, dried beans, and peas, a little bit of fats and oils, and minimal sweets. And this diet has been demonstrated to lower blood pressure. Now, the rationale of this in their paper about the DASH diet, what the authors say, I find fascinating, is they basically admit that a vegetarian diet is the way to go, but they don't think people can do it. So they say in their paper, the diet design goals were to create patterns that would have the blood pressure lowering benefits of a vegetarian diet, yet contain enough animal products to make them palatable to non-vegetarians. So there are other approaches to treating high blood pressure, and I'd like to provide these as options to my patients before I provide pills where they may be necessary. So relaxation definitely is potent in lowering the blood pressure. Yoga, Tai Chi, Qigong, meditation. There's data that all of these things actually do lower the blood pressure a little bit. Supplements can help to lower the blood pressure, things like coenzyme Q10, omega-3 fatty acids, L-arginine, hibiscus tea, ground flax seeds. I'm going to briefly talk about blood pressure medications, and the caveat that I give to anybody who I put on a blood pressure medicine is that medicine is never a forever thing. Blood pressure and lifestyle are fluid, and as people may improve their diets, improve their lifestyle, they may not need blood pressure medication, but perhaps at the time that I'm seeing them, their blood pressure is not controlled. And just to be clear, I do have patients who are on whole food plant-based diets who, in spite of their best excellent efforts, they still have high blood pressure and are on medicines to control their blood pressure. Now, the first line of choices for blood pressure typically are thiazide diuretics, so things like hydrochlorothiazide or chlorthalidone. There are other medications called ARBs or ACE inhibitors. These are good choices, or calcium channel blockers like amlodipine, felodipine, or diltiazem. These are the first line choices. Beyond that, there are other options. There are medicines that are called beta blockers, such as metoprolol or carvedilol, that can be used if another medication is needed, or if there's another condition like congestive heart failure, arrhythmia, or coronary artery disease. Now, my approach to medications for blood pressure is that I typically will start with one medicine, or I'll start with one combination. So it could be a combination of two medicines at low doses, because blood pressure tends to be more responsive to a combination of two lower dose medicines than to one medicine at a high dose. I will gradually increase the dose or add on medication until the blood pressure is controlled. And to be clear, people who are on blood pressure medicine, the average person is on 3 medicines, though certainly blood pressure could be controlled on 2 or even 1 medicine, or even with lifestyle alone. Now, medications are to be taken daily for blood pressure. They're not to be taken as needed. I have patients who come back to me and say, I checked my blood pressure was good, I didn't take my medicine. But then their blood pressure the next day is high, and so they take their medicines. Their blood pressure yo-yos up and down because they choose not to take their medicine when their blood pressure is under good control. And if you're on a blood pressure medicine, you need to take your medicine every day to keep your blood pressure fairly level and controlled. Now, the goal blood pressure with treatment is 130 over 80. The goal of treatment is not 120 over 80. Now, 120 over 80 or less in a normal person means you don't have high blood pressure, but we don't have data to treat blood pressures to that low of a level. Now, why might the blood pressure not be controlled? If somebody's not taking their medicines, that's pretty obvious. I know often people are hesitant to take medications and often need a fair amount of reassurance that blood pressure medication that they're prescribed is safe. They may not be taking their medications properly. So there are some medicines that might be twice a day, and somebody may be taking it only once a day, and that's not going to be effective. A diet that is high in salt, that's going to make blood pressure much harder to control. Pain, anxiety, stress, these are all things that drive up the blood pressure. Sleep apnea. Now, sleep apnea is a condition in which somebody has oxygen levels that drop dangerously low at night. while they're sleeping. And as a consequence of these low oxygen levels, there are changes within the body that can increase the risk of arrhythmias such as atrial fibrillation. It can cause a condition called pulmonary hypertension or elevation of pressures within the lungs, and it can actually raise the blood pressures during the day as well. So if there is suspicion that you have sleep apnea, such as that if you're sleepy during the day, if you snore at night, if people notice that you stop breathing or gasp at night, if you urinate frequently at night, those would be signs that you should be tested for sleep apnea. Alcohol consumption, so binge drinking, even just drinking once a week and drinking a whole lot, or drinking heavily throughout the week. These are both things that will raise the blood pressure. Weight gain, as we talked about with treating hypertension, weight loss lowers the blood pressure, but weight gain raises the blood pressure. And then overzealous blood pressure checking. I think that some people who tend to be a little bit more anxious will check their blood pressures multiple times per day. I mean, I get the occasional patient who says, well, I was not feeling so good. I had headaches, so I checked my blood pressure and it was high. So then I decided I was going to check my blood pressure 30 minutes later and it was still high. And then I checked my blood pressure 30 minutes later and it was even higher. And it's like, put your blood pressure cuff away for now and check your blood pressure again in the morning. And it goes back to the concept of checking the blood pressure at proper times of the day under proper conditions. So making sure that you're relaxed, that you're sitting in a proper place, the arm is at heart level, and so forth. So how I get my patients' blood pressures under control, I like to set realistic expectations. I ask my patients to bring readings from home so that I know what their blood pressure is when they're not in my office, because the outcomes of heart attack and stroke are dependent more on what the blood pressure is outside of the doctor's office than what it is inside the doctor's office. I like to make sure that I have an accurate list of all of a patient's medicines and make sure that I'm aware of any medicine that could raise the blood pressure. I also like to make sure that the patient is actually taking the blood pressure medicines that I've prescribed. And because I know that sometimes a pharmacy can make a mistake and dispense the wrong medicine, or they may not dispense their medicine, or they may dispense a medicine that I've discontinued. I like to make sure that a patient's blood pressure cuff is accurate. I'm always eager to have patients bring their blood pressure cuffs in and let us calibrate them in our office to make sure that they are accurate. I assess my patients' compliance and make sure that or at least ask them if they're taking their blood pressure medicine every day, and check to see if there are any side effects that can be attributed to blood pressure medications. And side effects can happen, but there are so many options for blood pressure that we can switch a medicine to something that typically will not cause a significant side effect to a person. With getting blood pressure under control, I'm not going to take somebody who's got sky high blood pressure and get them to a normal blood pressure tomorrow, because lowering the blood pressure rapidly is going to make them feel terrible. The body is, in this person, used to a very high blood pressure, and we need to get that body gradually accustomed to a lower and more healthy blood pressure. So I will make gradual changes, especially in older people, to their medications to get them to goal. I am somebody who is very vigilant about reinforcing lifestyle choices. So with every visit, we talk about diet, we talk about exercise. And I'm very much somebody who encourages communication between me and my patients between visits, either with phone calls or through my office patient portal. If somebody is having an issue and feels that their blood pressure medication is causing a problem, I like to know about it before I see them for a visit in the future. Now I'm going to talk a little bit about cholesterol. And what cholesterol is, it's a waxy substance that our body needs to function properly. We absolutely need cholesterol, but our body makes all the cholesterol that we need. Our liver makes cholesterol, but we can also consume cholesterol from our diet, namely animal foods. That said, processed foods, even if they are vegan, will raise the cholesterol levels. Now, cholesterol is carried in the bloodstream by lipoproteins. So when you have your blood work and you have your cholesterol levels checked, we're not actually checking those little cholesterol particles. What we're actually measuring are the lipoproteins. We're measuring the LDL, which is the low density lipoprotein, which functions to transport cholesterol from the liver to cells, to the arteries, to deposit in the lining and lead to plaque buildup. And then there's also HDL, which is also called high density lipoprotein, which carries cholesterol back to the liver so that it can be broken down and then ultimately removed from the body. Now, as cholesterol levels increase, the risk of coronary disease also increases. This is data from the Framingham study of people within Framingham, Massachusetts. It looked at patients or subjects who were 40 years old and what their cholesterol was at age 40. Those who had a lower cholesterol, those are the orange bars, had the lowest lifetime risk of coronary artery disease compared to those who had the highest cholesterol levels. These are people who had the highest incidence of coronary artery disease. Now, the EPIC study specifically looked at cholesterol levels based on diet. So meat eaters tended to have higher cholesterol levels, whereas vegans tended to have lower total cholesterol levels, and fish eaters and vegetarians somewhere in between. So a plant-based diet does lower cholesterol. And more specifically, this is taken from a paper that looked at several different studies that were dietary interventions to help to lower cholesterol. So a plant-based diet in all of these studies lowered total cholesterol, that's TC. It also lowered LDL cholesterol, that's the LDLC. And the effect on HDL, or high-density lipoprotein, tended to be fairly neutral. In some studies, there was essentially no change. In some, there was a drop. In some, there was a raise in the HDL cholesterol. The bottom line is plant-based diets definitely do lower cholesterol. I should say healthy plant-based diets lower cholesterol. Now, these are the numbers from one of my patients. This is a 53-year-old woman who initially saw me back in 2019, and we checked her cholesterol levels, and they were high. Now, to be clear, this is a woman who had no other heart risk factors. She doesn't have high blood pressure. She doesn't have a strong family history of heart disease. She just had high cholesterol. So we talked about what we could do to lower her cholesterol levels, and she decided that she wanted to adopt a healthy plant-based diet. So we rechecked her cholesterol 3 months later on a healthy plant-based diet, and her LDL cholesterol, or her total cholesterol, dropped from 252 down to 192, and her LDL cholesterol plummeted from 164 down to 106. Now, we actually recently just rechecked her cholesterol levels, and she's remained on a plant-based diet, and her cholesterols remain nice and low. So diet can be very potent in lowering cholesterol. That said, cholesterol medications may be appropriate for some people. Cholesterol medicines, they lower cholesterol, but they can also reduce the risk of a cardiovascular event. Now, we have two different categories of people. We have what's called primary prevention. Those are people who've never had any type of heart problem before. And then we have what's called secondary prevention. And that is somebody who has already had a heart attack, or we know has plaque in their arteries, or has had a stroke. And you can see from the graph, if you look at that, the blue line, that the lower the cholesterol, the lower the risk of event rates. Now, in the so-called primary prevention, people who've never had an event, there is that association, but it's certainly not as steep of a line between cholesterol and event rates. Now, what is a statin? A statin is a cholesterol medicine. It's also known as an HMG-CoA reductase inhibitor. It is a medication that blocks the HMG-CoA reductase enzyme in the liver and helps to block the production of cholesterol by the liver. And it is the most common class of cholesterol lowering medications. It can stabilize and it can reduce plaque in the arteries in addition to its ability to lower cholesterol levels. And it actually can reduce the risk of heart attack and stroke. So who should receive a statin for secondary prevention? So anybody, regardless of whether you're on a plant-based diet or not, all patients with atherosclerotic cardiovascular disease should be on a statin. So if you've had a heart attack or a stroke, if you have a history of angina or heart-related chest pain, if you've had a stent, if you've had bypass surgery, or if you have peripheral vascular disease or plaque within the arteries of the legs or the neck, you should be on a statin to work in conjunction with your healthy lifestyle to reduce your risk. So what about primary prevention? And the data for, if you've never had a heart problem before, it's not as strong, but there is some evidence that in the right people that a statin can help to reduce risk. So a statin can be beneficial and is recommended in somebody who's a diabetic over the age of 40 to help to reduce risk of heart attack and stroke. If you have an LDL cholesterol that's over 190, and that cutoff is chosen because people who tend to have cholesterols that high, it's not because they have a bad diet, it's because they have some sort of genetic abnormality or a familial hypercholesterolemia that causes their cholesterol to be at such high levels. And these people are at significantly increased risk of heart attack and stroke with time. So the recommendation is there that these people should be on a statin medication in addition to prudent lifestyle. And then others, depending on their risk, and that's what we call shared decision making. So I will often sit down with my patients and say, this is, these are your risk factors. And we have ways of calculating cardiovascular risk, and we look at what somebody's risk is over the course of the next 10 years. If the risk is somewhere between 7.5 to 10% or higher of having a heart attack or a stroke in the next 10 years, that's somebody who a statin medication might be reasonable for. And again, I don't force anybody to take pills, but we always talk about what the potential benefits of the medication are. Now, there are a lot of myths out there about statin medications, so I want to talk about these a little bit. So, statins will hurt my liver. And the truth is, drug-induced statin injury is so rare. I, in my career, have not seen one. There's never been somebody who has been required a liver transplant because they were put on a statin and it's destroyed their liver. Another myth, statins will cause muscle aches. Yeah, statins actually do in some people cause muscle aches. It's about 5 to 10% of all people. It's not a permanent damage to the liver. You stop the statin, the muscle aches will go away. There's a very rare thing called rhabdomyolysis. I've seen a very small handful of patients who've had that from statin medicine. And again, that is something that with stopping the medicine gradually, that will also improve with time. And those people who do have muscle aches on one statin often will be able to tolerate a different statin. Another myth, statin causes diabetes. Now, statins do not take somebody who has perfectly normal sugar and transform them into being a diabetic. What it does do is a statin does, as part of its action, it does slightly increase the glucose level. So if you are somebody who is pre-diabetic right on the edge of diabetes, it might push you right over that classification such that you are now considered to be a diabetic. But the benefit of this person being on a statin typically in reducing the risk of heart attack and stroke will outweigh that small change. Another myth, statins cause dementia. The truth is there really is no proven link between statins and dementia. Statins actually do reduce plaque over time and may actually reduce the risk of memory problems in the long term. And the final myth, if you're a skeptic, you may be thinking Dr. Shenkman is a shill for big statin. And at this point in time, there really is no big statin. Most statins are generic and there is no money to be made in prescribing statin medications. So finally, the point of my talk is that you can be successful with a plant-based diet in helping to keep your heart healthy for years to come. it doesn't matter where you are. If you're concerned about your family history, if you're somebody who's already had something happen to you, if you've had a stent, if you've had a heart attack, it's never too late to start taking good care of your body, putting good plant-based food into your body. And a plant-based diet goes hand in hand with good medicine for the long term. It's not medicine versus diet. It's a combination of a plant-based diet and good medicine where appropriate to keep your heart healthy for years to come. And I guess I chose this picture for success. This is me back in 2013 competing at the Maccabiah Games Olympic distance triathlon in Israel. And finally, if you want to learn more, read more, buy my book. It's available on Amazon, The Vegan Heart Doctor's Guide to Reversing Heart Disease, Losing Weight, and Reclaiming Your Life. And if you happen to live in the Los Angeles area, I'd be glad to see you as a patient. If you live in California, in the state of California, the only state where I have a medical license, I can see you as a consultation via telemedicine as well. And I think from here, I will open it up to questions. And I thank you for the opportunity to speak.
And thank you so much. This was so thorough, and so meaningful for so many people. Really appreciate this. And obviously, there's the information, folks, if you want to reach out. Find Dr. Shenkman's book. And from there, if you're ready, we'll take those questions. I just want to make sure everybody understands how we go about doing this here at The Real Truth About Health. And that is that we ask everybody to raise their hand. There's already hands being raised. And so with that, if anybody doesn't know how to raise their hand to ask a question, we ask you to go to all of your Zoom tabs. Sometimes they're at the bottom, they might be somewhere else. But you click on the reactions tab, and when you're once you click on the reactions tab, you'll see a function that says raise hand. You go ahead and click that. We'll see your hands come in, and we'll go ahead and take your questions, as many of them as we possibly can during this time. And so, Dr. Shenkman, if you're ready, we'll jump right in.
Okay.
Excellent. Thank you. And so let's go to Aaron or Aaron. You are unmuted. Welcome.
Hi, can you hear me?
Mm-hmm.
So first of all, thank you for the great presentation, Doctor. A few years ago, I made a CAT scan and find out that I have about 50% blockage in my arteries during this test. And I decided to change my lifestyle to become a fully vegan. And I was wondering if you can recommend any type of test to check if, my arteries now is better, because I'm afraid to do another CAT scan because of radiation. Not sure if it will be effective. Are there any tests that you're familiar with that you would recommend to check the status after a few years and changing the lifestyle?
That's a great question, Arun. First of all, congratulations on making positive changes and taking control of your health. That's wonderful. As for what one should do with that information, now, I would recommend that you be under the care of a cardiologist, but in general, a 50% blockage, if you are not having any symptoms, there is no reason to do any further testing. And you make a really good point. You don't want to expose yourself to additional radiation that can cause problems for you in the future. So I would say that you should be consulting with your local cardiologist or primary care doctor. But if you're feeling well, you probably don't need to do any further testing.
Thank you very much, Doctor.
Thank you indeed. And now we have up next somebody with the initials DS. DS, welcome.
Oh, hi. Am I unmuted?
Yes, you're unmuted. You're set. Thank you.
Great. Yeah. Thank you for the presentation. I have been a whole food plant-based for about a little over 4.5 years, and I'm doing really well. Weight is good. Blood pressure is good. All my biomarkers are good. I'm running marathons. I mean, it's been great. But my cholesterol is still a little bit high. I got my cholesterol checked 2 years ago, and it was like 197, and LDL was like 108, so like a little higher than you want. And then I've been a little bit slacking and eating a little more of the vegan junk food, not a lot, but enough more that when I got it taken again this year, it went up to like 230, and the LDL is like 120. So I really do not want to take a statin. But I was wondering what you thought about plant stanols, and also I've heard some good things about amla powder.
Okay. Both plant stanols and amla powder, they do both lower cholesterol. The cholesterol numbers you described to me, they are above the optimal, but they're not terrible. I think you probably know the answer to much of this, in that you've incorporated more junk food into your diet, the cholesterol levels went up. Going back to better eating certainly will get your cholesterol back to better levels.
Excellent. Thank you very much for that, Doctor. And let's now go to Cheryl. You are unmuted. Welcome.
Thank you, Ben. Can you hear me?
We can. Thank you.
Thank you. And thank you, Dr. Shenkman. Great presentation. My question is about lab tests and the different lab reference ranges that they use. For example, I recently had an omega-3 test, and my index was about 4, a little over 4, and the lab rated that as optimal and rated me as low risk for heart disease. And then when I was doing some other checking online, I found out that other labs have a range going up to 12, and they think 8 is optimal. And so how do I make sense out of this? Because I don't have any illness that I'm aware of right now, but I don't want to have a surprise one day.
Okay. It's a good question, and I don't know that I've got a perfect answer for you. I do not routinely check omega levels in my patients. There really isn't strong data to suggest that knowing omega levels is going to affect your long-term health. As for the reference values, I think that for each laboratory, they may have a different assay. So a value of 8 in one lab may not be the same as a value of 8 in another lab, and hence they have different reference values. But I would talk to the doctor who ordered the omega testing for you.
Excellent. Thanks very much, Dr. Shenkman. And now we're going to go on to Janet. Hi, Janet. Welcome.
Hi, thank you very much for the presentation. I just had a question for my husband. He's been vegan for some time, mostly whole food, plant-based, but he does eat a lot of, likes to eat a lot of nuts and seeds though. He has slightly elevated cholesterol, but he's not overweight. But when he's sort of doing his day-to-day things, he gets out of breath easily. He's like in his late 40s. So just wondering what kind of tests he could do for like his heart function, just to make sure he's okay. Even just like walking up the stairs, he can be sort of out of breath sometimes.
Oh, that's a good question. And those are some concerning symptoms. I think that your husband needs to see a physician, and see a physician soon. There are a few different tests that can be done. One of them could be a stress test, another could be an echocardiogram, but certainly I think that whomever he sees would need to take a fairly detailed history and examine him and decide exactly what's the appropriate test. But please get him seen soon.
Sage advice. Thank you very much for that. And up next, we have Paul. Welcome, Paul.
Hello. I'm unmuted automatically, I see.
Yep, we got you. Thanks.
Okay, great. Thank you, Dr. Shenkman, for this presentation. I have a couple of quick questions. One is, why, when I take my blood pressure standing up, do the top and bottom numbers usually reduce by, say, 10 points, or sometimes even more?
Okay, well, the natural response of the body is that the body needs to accommodate different positions. So there is going to be a slight difference in blood pressure between sitting down, lying down, and standing. It also much depends on how quickly you check your blood pressure standing up. If you stand up quickly and then check your blood pressure is going to be lower than what it truly is if you've been standing for a while. A difference of 10 points is not significant. Typically, we consider a difference of a systolic blood pressure between positions of 20 points as being significant. And if you're lightheaded with changing positions, you should talk to your doctor about that. But if you're not lightheaded with changing positions, I don't know that you need to be checking your blood pressure standing up.
Thanks, doctor. And Paul, was there a second question you said you had?
Yeah, okay, very quick. I'm a 62-year-old male, a bit overweight. I was prescribed metoprolol and also terazosin, which is also affecting the enlarged prostate. Well, I found the side effects on the terazosin to be too much for me. So I stopped the terazosin, and now my blood pressure is usually in the 140s on top and in the 90s. Is the terazosin, was that also prescribed for blood pressure along with the metoprolol, do you think?
I would talk to your doctor about that. Terazosin does naturally lower blood pressure, but I think that if you have the blood pressures that you're describing, you should speak to your doctor about whether you should have a different medication for blood pressure control or get some advice on lifestyle to help to lower your blood pressure.
Thanks for that, Dr. Shenkman. And up next, we have Sylvia. Welcome, Sylvia.
Hello. Thank you, doctor, for your presentation. I have a question. I am obviously female, but I weigh about 103. My blood pressure is always pretty low. I was wondering, is that a concern? It's usually like around 97 over 60, or it's even been lower than that. Is that a problem?
If you are able to stand upright and do the things you need to do, your blood pressure is fine. The lower, the better, as long as you're feeling well. My blood pressure runs about what yours does.
Excellent. Thank you for that, Dr. Shenkman. And up next, we have Kaylee. Welcome, Kaylee.
Hi, thank you. Thank you for a wonderful, wonderful presentation. Please, it's a couple of things related to AMLO. What is AMLO? Are there contraindications for it? What does it do? And is it related to amlodipine? Because I had a horrendous experience with amlodipine.
All right. AMLO and amlodipine, fortunately, have nothing to do with one another. As for the details of what AMLA is, I honestly, I don't know the details of that. So I apologize. I can't answer that question. I do know that it does naturally lower blood pressure. I'm sorry, naturally lowers cholesterol. My bad.
Excellent. Thank you for answering that. And now we've got Stephen F. Welcome, Stephen.
Hi. Thank you, Ben. Doctor, the other night we had this panel with Dr. Joel Kahn and some other cardiologists and Dr. Baxter and some doctors and some researchers that were questioning the standard of care when it comes to prescribing statin drugs, that they were well less than 2% effective, and that you would have to treat 500 or 1,000 patient years to prevent one heart attack or stroke. And all they kept saying was that this information is not something that is routinely shared with patients. All they're told is you have to take this or you'll die. That's my question.
Okay. You have to take this or you'll die is a horrible way to tell somebody to take medication. As I talked about, it's about shared decision making. So we discuss what the risk of or what the benefit of a statin would be. So it depends on the patient population. You mentioned the number needed to treat. So the number of people who need to get a statin pill to get a benefit, it depends on what their underlying conditions are. Now, somebody who is otherwise healthy, who's walking around and running marathons and has an LDL cholesterol of 120, you would have to take like more than 1,000 of them and put them on a statin for 10 years to prevent one event. Yes, that is correct. That is somebody who would not benefit from a statin. However, somebody who has already had a heart attack and stroke, there is no question that the number needed to treat is significantly lower in order to reduce the risk of that person having another event. And it's always a gray area. And again, it's a conversation that I have with every patient before I put them on a statin. This was why we're doing it. This is why your risk is high and why a statin will help to reduce your risk. If somebody who's a lower risk person, I'm not going to push a statin at them, but it's always a shared conversation where we talk about the risks and the benefits.
Thanks very much, Dr. Shenkman. And now we have a question coming in from Sky. Hi, Sky.
Hi, how are you? Thank you, Dr. Shenkman. I have a question. So I've only been a nurse for 2 years, but I have in that time seen quite a few patients come through our rehab center with rhabdomyolysis. And my question about statins is I've heard that it does deplete the coenzyme 10, which is what causes the rhabdomyolysis. Do you suggest your patients take coenzyme along with the statins when you prescribe it?
It's a good question. Yes, it does deplete coenzyme Q10, but we don't have really good data that shows that coenzyme Q10 supplementation reduces the risk of muscle aches. The data just really isn't there, even though there have been trials looking at it. I think it's a reasonable thing to do if somebody wishes to take a coenzyme CoQ10 supplement. I think it's a reasonable thing to do, but it's certainly not mandatory.
Excellent. Thank you for that. And we have a question now from Ainsley. Welcome, Ainsley.
Hey, everybody. Good afternoon. Doctor, is there a safe salt for us to use on our foods? What is your favorite salt of preference? Himalayan, sea salt, regular salt, free salt that we get in the packets from the grocery? Talk to us.
I personally don't add a lot of salt to my food. I would say that use the salt that you like the best. There's really no data to show that one salt is better than another when it comes to the heart, but certainly you want to be judicious in your use of any salt in cooking.
Great. Thanks very much for that. And so at the moment, I don't have any more raised hands. I've got a few questions for you, and maybe we'll see if anybody else wants to raise their hand along the way. And so if that's okay, I'll jump in. I am wondering, where was the one I wanted to ask you about? For people, I guess the question is, and you may have covered this, but tell us a little bit more. Does diet help for someone who's having chest pains and heart issues, or is it too late for them and they absolutely need stents and surgery?
I think it really depends on where the chest pain is coming from, but diet changes are always appropriate at any time along the whole continuum of this. But if somebody is having chest pain, that's not a situation where you say, oh, I'm going to go vegan, or I'm going to go eat some fruits and vegetables, I'm going to be better. If you're having chest pain, you need to be evaluated by a doctor.
That certainly seems to make a lot of sense. And actually a hand got raised while we were doing that. So I will unmute Stephanie. Welcome, Stephanie.
Hi, doctor. Thank you for answering our questions. My question is, I'm on amlodipine and metoprolol, and of course, I've adopted this plant-based lifestyle in hopes of weaning off or getting off of those medications. But I read something the other day that was kind of scary. It said that if you get off of metoprolol, like just get off of it, it can cause a heart attack, I guess, or whatever. So I was wondering, in your opinion, what's the safest way to get off of a drug that you're on for like a tachycardia or something, or in high blood pressure? And is there a best way to get off of medications?
Before you even think about stopping the medication, talk to your doctor, see if there's a good reason why you should be on that metoprolol and if it can be substituted for something else. Now, stopping metoprolol isn't necessarily going to cause a heart attack, but what happens is your body is withdrawing from the beta blocking effect of the metoprolol. So you can actually have an increased risk of arrhythmias, an increased risk of heart attack. When I take patients off of metoprolol, what I will typically do is I will have them gradually wean off of it. So we might go down to like a half of a tablet for a week and then stop the tablet entirely. But before you even think about stopping the medicine, please talk to your doctor.
Excellent. Thank you very much. And now we have Aaron. Welcome. Oh, hang on. Let me unmute you one more time. Hi, Aaron.
Hi, can you hear me?
Yes, thank you.
Hi, so I asked a question before, but this is a kind of a follow-up question to a question that's been asked about the omega-3 score. So I diagnosed in my blood test as a serious deficiency of omega-3. I've been told that the number should be 5 and my number is just 1. And as a vegan, I don't want to use fish oil pills. And I've heard that the DHA from algae tend to be very oxidation issues. What would be your recommendation to deal with the serious omega-3 deficiency? And does it might affect the heart health?
It's a good question, and I want you to definitely talk to your doctor who's ordering the omega-3 levels as to what they think you should do to replete your omega-3 levels. As for oxidation and algae-based omega-3, that's not something I've heard. And personally, I actually do take an algae-based omega-3 on a daily basis for my own health. But I would talk to your doctor.
Excellent. Thank you very much for that. And we now have Mike. Go right ahead.
Thank you, doctor. Just a quick question. I eat a lot of healthy greens to get the nitric oxide to help to dilate my blood vessels. But I also the question I wanted to ask is, in addition to that, I have taken sustained release niacin in the past, and I feel the flushing, which my brain tells me that's a good thing because it's flexing my vessels and making them maybe more. Is there any downside with too much flushing? Is it a negative or a positive?
I don't think that there is a downside to the flushing, but just that some people find it to be a nuisance. For the very few people that I prescribe niacin for, because it's just not a medicine we use much anymore, just because there's not a lot of data demonstrating benefit for most people. If I do recommend niacin, I will recommend that somebody takes 4 baby aspirins and chews them about 30 minutes before taking the niacin, and that can help to decrease the flushing side effects.
And thank you for that, Dr. Shenkman. And we now have Melissa. Welcome, Melissa.
Hi, thanks, Doctor. Thank you for your time. So a few questions, please. Does coffee affect blood pressure? I am plant-based for about 2 years, and as of January, SOS free. What would cause high blood pressure? Could it strictly be a lack of exercise? And is walking good, or do you need a more rigorous workout plan so many days a week? Thank you.
Walking is good exercise. Depending where you're at, if you're somebody who's relatively fit and you can do something a little bit more vigorous than walking, then that's great. But walking is always a good starting point for blood pressure. I think there were a few questions in there. I'm going to try to remember them, but you had also asked about coffee and does coffee raise blood pressure? And yes, coffee does slightly raise blood pressure, but there are also some beneficial effects of coffee on the heart. So I tell my patients that if you enjoy coffee, drink your coffee, just don't turn it into a big sugary, messy beverage.
That seems to make sense. Thank you very much for that. And now we have Paul coming in. Welcome, Paul.
Hi, thank you again. Yes, doctor, I've been, instead of low-dose aspirin, I've been using nattokinase. Do you know much about nattokinase? Everything I've read really touts it highly.
It depends on what you're using the nattokinase for.
Blood flow.
Okay.
Instead of the low-dose aspirin.
Okay, it depends on what your indications for an aspirin would be. If you're somebody who's had a cardiac event, or you have known arterial disease, I would say you should be taking the aspirin. There really isn't, unfortunately, there isn't a lot of good data. There's a lot of data that shows that if you do have heart disease, that there is benefit from a baby aspirin, and we don't have that for nattokinase.
Okay, thank you, doctor.
Thanks very much for that. And so again, if anybody else has a question, feel free to raise your hand. I'm going to jump into another one for now. And that is that, some people are out there saying that the best oils are saturated fats, such as coconut oil and ghee and butter and lard. And what does the science say?
The science would suggest that diets that are higher in those saturated fats tend to have an increased risk of cardiovascular disease. So I encourage my patients to stay away from those things.
Got it. Thank you for clarifying that for everybody. Let's go to somebody with the first initial M. Initials M-E. I just asked you to. There you go. Hi.
Hi. Wonderful presentation. Thank you so much. My question is regarding, I have a condition called left bundle branch blockage, and I also have a congenital minor heart murmur. I've been vegan about 30 years, mostly whole food, plant-based, and just wanted to see if you have any recommendations regarding food or any specific things, because my doctor said, I have no idea. And the research I've done in PubMed and elsewhere, there's very little that I've been able to find about it.
Okay. I don't know that I have any specific recommendations regarding the conditions you described and diet. Now, you have a left bundle branch block. Just to be clear, it's not a left bundle branch blockage. A left bundle branch block is a conduction abnormality of the heart. It's not a blockage. As for the murmur, it really depends on what the murmur is due to. But if you sound like you've done a lot of research on your own, I really don't have anything to add.
It is the conduction issue.
Yes, I know.
And I'm just trying to understand, how did that happen? Was I short on some minerals or something?
No.
I mean, I'm just trying to figure out how did that happen, because I've been active and healthy for my whole life. So
sure. So a left bundle branch block is a electrical abnormality that can be a consequence of a condition of the heart, and that is something that should be investigated by a cardiologist with an echocardiogram and potentially stress testing to look for whether there is an underlying heart condition that is responsible for the left bundle branch block. But that said, there is a fraction of people who may have a left bundle branch block in a completely normal structure of their heart otherwise.
Thanks, Dr. Shenkman. And now we're going to go to Elaine. Hi, Elaine.
Hi, how are you? Can you hear me?
We can, thank you.
Oh, okay. One quick question, and it probably will. Thanks for a great presentation. And it may be a very silly question, but correlating your high blood pressure and your LDL or your cholesterol, as you lower your cholesterol and get it down, shouldn't your blood pressure also come down?
That's a really good question. And that actually would make sense, because the things that drive up cholesterol in many cases also drive up blood pressure. So yes, if you make changes that improve one, the other will probably also improve.
Excellent. Thanks, doctor. And thanks for the great question, Elaine. And now we're going to go to Wayne. Welcome, Wayne.
Thank you. I've been cycling for the last few years and usually without any problems, but recently I've had experienced hypotension, a little bit of dizziness after cycling for about 30 minutes. And I've been reading about this, and I see that post-exercise hypotension is not unusual, but I'm just curious why I'm not beginning to experience this, and if there's anything that I can do to prevent this or minimize it.
So you're asking about hypotension or low blood pressure after you exercise. So to be, I just want to understand, are you lightheaded or is your blood pressure low or both?
Both.
You're checking your blood pressure and your blood pressure's low. Okay.
Yeah. It's about 10 millimeters to 50 millimeters drop that I experienced after comparing the blood pressure after 30 minutes of riding compared to when I start.
And you're lightheaded as well?
Sometimes. I've now got to the point where I can detect it and I'll stop riding at that point, but yes.
Okay. I think you definitely need to be seen by a doctor and have that evaluated further, but certainly start with the basics of making sure that when you are riding that you are hydrating appropriately.
Excellent. Thanks for that, Dr. Shenkman. And looks like Stephen F. is back. Welcome, Stephen.
Hi, I'm back. More questions about the standard. Oh, first of all, I knew a young fellow that was a pilot and he was going for his medical review and his cholesterol was up and he went to Costco and bought a 55-gallon jug of niacin and gave himself severe liver damage. Not good. A question about the standard of care when it comes to angioplasty. Found myself in the hospital with a cardiologist who did a high-speed CAT scan when they first came out years ago and gave me a clean bill. At that time, they were also pushing angioplasty. And there was, I don't know, something on my EKG that freaked everybody out. Next thing I know, I'm back in the same emergency room. And they were adamant that, you know, I'm 14 years older, you need to have angioplasty. And I just, you know, and it was awful. There was like no informed consent. It was like, you know, the same thing like take this or you'll die. Same terrible pressure, both from the interns and the residents, and it was awful. And the next morning, finally, they admitted me and I had to agree to take a thallium stress test. 4 hours later, they kicked me out of the hospital. They said, your volume going in and going out is perfect. You're fine. But they wanted to do an angioplasty in the worst way. Again, what's up with the standard of care in cardiology? Thank you.
I'm sorry you had that experience. It sounds like that was pretty traumatic. So angioplasty, the standard of care is not necessarily practiced everywhere by everyone, but what our societies recommend is that an angioplasty is definitely indicated, I should say revascularization, whether it be with an angioplasty or a bypass, is indicated in the setting of an acute heart attack, or an unstable cardiac event, or in certain anatomical situations, such as if there is severe disease of the left main coronary artery or severe 3-vessel coronary artery disease. If you are an otherwise stable patient who has the incidental finding of a blocked artery, putting a stent in is not something that's going to reduce your risk of heart attack or stroke or prolong your life. And that's something that when I do procedures on my patients, I make very clear to them that if we're going to be doing an angioplasty, it's to open an artery and improve their symptoms. It's not necessarily to save their life if, in fact, I am not taking care of them in the setting of an acute heart attack.
Thanks, Doctor. Looks like Stephen has a quick follow-up to that. Hey, Stephen.
Yeah, like I said, there was no blocked artery. It sort of felt like the gastroenterologist with the colonoscopy. You know, I can see what's going on when I go in there if there's a problem. That was the push.
Okay. Unfortunately, not being there, I really can't comment on that. I'm sorry.
That makes sense, Doctor. Thanks very much. And again, at the moment, I have no other raised hands. I'm going to go ahead. I've got another question for you, and that is, do whole food plant-based eaters need to get scans to check the health of their arteries? And if so, which ones?
Okay, good question. So who needs to get scans of their arteries? And the short answer is no one. It's if you're feeling well and you're doing fine and you're able to exercise and you're not having problems, you don't need to have any type of artery scan or stress test. I think it depends, regardless of what you're eating, it really depends on the clinical scenario. If you're somebody who's having symptoms, you have chest pain or shortness of breath, or you have a significantly abnormal EKG or some other significant findings, then that would indicate further workup. But we don't routinely do heart scans on people arbitrarily.
Got it. Thank you. I've got another question, and that is, are there generally specific drugs that you recommend for people with heart disease?
I think that's a pretty broad question. Again, given that heart disease is a pretty broad catch-all. For people who have coronary artery disease or arterial disease, I recommend an aspirin and a statin for everyone. And the American College of Cardiology and American Heart Association guidelines would endorse that as well.
Fair enough. That makes sense. Thank you. I do have another question, and that is, are there nutritional supplements, vitamins, minerals, powders, probiotics that you might typically recommend for those cases as well?
For which cases? I apologize.
Well, for people with heart disease, but you had mentioned, that it's a broad spectrum. So I don't know if there's any, generally speaking, do you predominantly recommend any of those types of things?
In patients who do have heart disease, I don't typically push any particular supplement. I use what has evidence base behind it.
Okay, excellent. Well, I would say at this point, I think we have fulfilled our queue. No, I was going to say I think we're done with questions, and looks like I have one that just came in. So let's go to Alejandro. Welcome, Alejandro.
Hi, thank you for that great presentation. That was great. I felt like I was in the driver's seat from like all of your experience as a doctor. So thank you. And my question is there any information you can share as far as the effect of vegetable oils versus saturated fats on cholesterol and blood pressure on the arteries? Do they both affect your cholesterol levels? Is one worse than the other? Say, for example, compare a steak with like a processed snack with vegetable oils. That makes sense?
It makes sense. And it's hard to drill down, a specific food's effect. But in general, I can tell you that saturated fats tend to raise the cholesterol levels significantly more so than say, a vegetable oil would.
Okay, thank you.
Thank you for that. And we also have another question coming in from Dave. And welcome, Dave.
Thank you. Hi, doctor. Great presentation. You might have covered this and I missed part of the presentation, but I have a quick question as far as I eat healthy, I exercise, I get enough decent sleep. Number one, do you recommend any other tweaks that you think like on your daily schedule that would improve our, long-term, health that you didn't cover that you could think of? And then how much would you say is stress a bigger factor than your food consumption, or is food the primary, contributor to heart disease?
It's a good question whether stress or food is more important. I think it really depends on what the stress is, certainly. And it's hard to quantify stress, but I think both eating a healthy diet and managing stress are very important for not just heart health, but overall health. As for what I may not have mentioned in my talk about healthy lifestyle, and I think it's important to have a good routine. And yes, there are times you deviate from it, but that, for example, like you wake up and then you have your coffee and then you work out and then have your breakfast. I think sometimes having a routine is beneficial for maintaining good healthy habits.
Excellent. Thank you very, very much for that, doctor. And again, I think, and MA is back. So we've got another question. Welcome, MA.
Hi, doctor. Thank you again for that wonderful presentation. And I have a little question here. So I'm trying to get my blood pressure down. It's not terrible, but I like salty food, so it's kind of hard. I'm trying to not eat salty food. Okay, so in some of the presentations on the microbiome, they have said that fermented food is very good for the microbiome, one of which is sauerkraut. And I like sauerkraut, but it's salty. So left or right? In other words, do you not eat the salty sauerkraut because that's bad for the blood pressure, or is it okay, to improve the microbiome?
I think you balance it with the rest of your diet. So you look at the rest of your diet. If the rest of your diet doesn't have other things that are very high in salt, perhaps a small amount of sauerkraut may be beneficial and okay for you.
Excellent. Thank you, doctor. And got a couple more questions coming in. And this one is, I hope I pronounce your name correctly. Is it Zinnia? Welcome.
Yes, it is. Yes, it is.
Welcome. Welcome. Thank you.
Thank you. It's very interesting. I live in Ethiopia. I lived in the US for 47 years. Then I moved back here. So I did some naturopathic studies in the USA. But anyway, so this is a good discussion. My question is in regards to high blood pressure. Do you test for the aldosterone levels when you do the blood pressure? One. The second question is, to lower the blood pressure, can you use the CoQ10, coenzyme Q10? That's the two questions that I have for you. I appreciate it.
All right. So when it comes to aldosterone, I think it really depends on the person. I get a basic metabolic panel to look at electrolytes and kidney function, because that can clue into a problem with aldosterone and blood pressure. But as for checking aldosterone levels, I don't check them on everyone who has elevated blood pressure. And coenzyme Q10, yes, it does have some beneficial effects in lowering blood pressure.
Excellent. Thank you. And now we've got a question coming in from Elaine. Welcome, Elaine.
Hi, I was wondering if you could talk about the cardio IQ labs and whether those are worthwhile for healthy or patients that have compromised heart function, and how often should labs be done of that nature?
So the cardio IQ labs really drill down into particle size and check some other markers like Lp(a), which is lipoprotein A. And I really don't use them much of at all, because they don't necessarily tell me a whole lot more about a person, and they're not necessarily going to change the treatment that I would provide. I think that knowing something like what a lipoprotein A level is, knowing once whether somebody has a tendency towards that's an additional risk factor, and that might lead me to be a little bit more aggressive with that person. But in general, I don't use them a lot because we just don't have a lot of data on how to use that information.
Got it. Thank you very much for that. We've got a couple more questions coming in, and this one is from Janet. Welcome, Janet. Oh, I'm sorry, Janet. I didn't unmute you. Let's try that again. Hi, Janet.
Oh, hi. Thank you very much. I just had a quick question. If you have low blood pressure and feel kind of dizzy, is it okay to have some salt, or is it better to have something like kelp or nori or something like that instead? Or just wanted to know.
I think all of those are good sources of salt, but if you're lightheaded on a regular basis, you need to be talking to your doctor about why that might be the case.
Sage advice. Thank you for that. And we have a question coming in now from Ben, and welcome back, Ben. No, I muted you again. Let's try that again. Hi, Ben. Now we hear you.
Yeah, I'm sorry. Thank you very much for giving us the good lecture. And my question is, do you recommend the people to take the multivitamin with omega-3? Multivitamin with the omega-3.
Okay.
Do you recommend? Do you just suggest people to take multivitamin supplement?
I think it's a reasonable thing to do. Yes.
Okay. So take a multivitamin with an omega-3, right? You're saying it's reasonable.
I think it's a reasonable thing to do. Yes.
Excellent. Okay, great. Thank you very much for that. We have just a few minutes left, folks. If anybody out there would like to have this intimate opportunity to speak with Dr. Heather Shenkman, please go ahead and raise your virtual hand again. We are thrilled to take your questions. I wonder, Dr. Shenkman, I've just seen somebody close to me dealing with heart disease, had 5 stents put in, subsequently after that had a pacemaker put in, not the best diet. And ultimately, I guess my question is what do you tell people about dealing with the initial pain, the acute pain immediately after surgery? Is there anything that you recommend to people that they may not be thinking about? And does changing their diet help with that acute pain afterwards? I don't know if that makes any sense, but I'm curious about your thoughts.
Well, I'm a little bit unclear about your question. When you say acute pain afterwards, you mean?
I guess just post-surgery after getting stents and a pacemaker put in, folks are dealing with the fact that they're just in pain for a few weeks. I'm just wondering if there's anything you recommend that from a plant-based direction or something that might be a little more natural than what the hospitals are telling folks to deal with.
You should not be having severe pain after the placement of stents or a pacemaker. I mean, a pacemaker, there is an incision in the chest wall. I mean, that may take a couple of days to heal up, but you shouldn't be having severe pain for days and weeks afterwards. So that's a problem.
So they would need to go back and see their doctor again. Okay, got it. Excellent. Thank you. Well, again, I would say at this point, it looks like we are, folks, anybody else got another raised hand? We've got a few minutes before we start our next. Oh, there you go. Jonathan took us up on this. Let me go ahead and unmute Jonathan. Hi, Jonathan.
Yes. Welcome. Hi, welcome. And thank you so much for that great presentation, Dr. Shenkman. I felt like I went through a science class again. Anyway, I have a quick question regarding exercise. So I see some people do intermittent fast sprint exercise, and I do more endurance. I swim 2 miles a day, 5 days a week, continuously. Which is better for the heart endurance long-term muscle, the intermittent workouts, those speed workouts and stop, or continuous endurance without stopping?
I think a good mix of both types of exercise is ideal. So not just doing sprints or just doing slow, long distance. Mix it up. That's what's going to be best for the heart.
Excellent. And to that end, obviously, some people are playing more with cardio. Some people are more into the weight training. Do you feel that one is better than the other for the heart?
I think both are important. If you can do both cardiovascular exercise and strength training, I think it's going to be ideal. Strength training does have some benefits, but if you really are limited on time, then do the cardiovascular exercise, make that a priority. But strength training definitely has benefits. It helps to improve our balance, our stability, our bone density as we get older.
Excellent. Excellent. Thank you. And now we have another question coming in for Aaron. Welcome back.
Yeah, hi. A quick question. What are your thoughts, doctor, about red yeast rice as alternative to statin?
Red yeast rice actually has a statin in it. It has a medicine called lovastatin in it at a very low dose. It also has some other things in it. It is a reasonable thing to take to lower cholesterol, but it certainly doesn't have the benefits that a statin would.
Got it. That sounds good. Thank you very much for that. And again, we've got maybe one more minute if anybody else has another question. And I would say at this point, we're probably pretty good, Dr. Shenkman. Is there anything else you want to add that we haven't covered?
No, thanks for the good questions and the opportunity.
Well, listen, I just want to say thank you so much for your, again, just very thoughtful presentation. It was very thorough. Looks like we do have one last question. So Xenia has a follow-up. So let's get to her real quick while we have one more minute. Thank you.
Thank you for taking my call. Thank you for taking my call. How about the eggs? Eggs, eggs have been talked about like they raise cholesterol levels so high, but the new information that I read is the eggs, the yolk especially has niacin it tends to lower the cholesterol, the bad cholesterol levels, and raise the good cholesterol levels. What do you think about the eggs? Well, depending on how you cook it also. You know, if you do bad oils, then you go rancid. So your thought on that?
Yeah, one egg contains 290 milligrams of cholesterol. So without question, eggs raise cholesterol levels. And there is some data that suggests that the more eggs you consume, the higher your risk of cardiovascular disease and the higher your risk of all-cause mortality.
There it is, plain and simple. So again, thank you, Dr. Shenkman. A great deal of gratitude we have here at The Real Truth About Health for you to be here and join us and share what you shared today. You were very gracious with our questions, so thank you for that as well. And I know I'm not the only one that wants to thank you, so I'm going to have my tech team unmute our entire audience. Please, everybody, what would you like to say to Dr. Heather Shenkman?
Awesome. Thank you.